Assalamu alaikum. Today we have a horseshoe kidney and it has got a PUJ obstruction. The details are shown on the screen, the CT scan and the DTPA scan. So we have mobilized the colon, we have lifted the liver, retracted it, and we are dissecting the pelvis first, instead of going for the ureter, because the ureter will be placed medially. We didn't place any ureteric catheter or the DG stent because that would lead to decompression of the pelvis, making the subsequent dissection and identification difficult. However, it can make the identification of the ureter easy. So we decided to go for the pelvis first. So here you can see that the renal vein was visible higher up, and this is the lower pole of the kidney and the lower polar vessels. The gonadal vein is draining into the renal vein, and the vein to the lower pole vein, which is draining the lower pole, is joining the gonadal vein, and both of them are then going into the inferior vena cava. So we found that the pathology here was the so-called aberrant vessel, although they are not aberrant. Just the anatomical location is abnormal. You can see that there is a vein and there is a pulsating artery. So we are trying to find the ureter here. The lower pole of the kidney has started showing up, and we look for it, and we see that there is a peristaltic movement in the fat behind the vein, the gonadal vein. So we are now sure that this is the ureter. Yes, this is the ureter, and we can dissect it. Remember the principles of pyeloplasty. The same principles they apply to the horseshoe kidney as well. So mobilize the ureter to the minimum, and mobilize it with the periureteral sheath in order to preserve the blood supply to the ureter, so that devascularization is avoided. And another important thing in the mobilization in the lower polar vessels is that you should not dissect the vessels from the ureter or the PUJ. Rather, you should dissect the PUJ from the vessels in order to avoid injury to the artery, which may compromise the lower portion of the kidney. So here you can see a narrow segment as well. So here both the internal as well as the external factors, which are also called as the intrinsic and extrinsic factors, they are playing a role here in the obstruction. So then we grab the renal pelvis and we pull it upwards. So this is the sequence of dissection for pyeloplasty in lower polar crossing vessels. You dissect from the below the ureter, and then you pull the pelvis and the PUJ above. You dissect it from there, and once you do that, you come to the ureter again lower down, and you pull the ureter towards yourself, and then you dissect more. So slowly and gradually the pelvic the PUJ and the pelvis is dissected away from the vessels, avoiding injury to the vessels. Here you can see that the segment has come down very easily, so it is mobilized from all sides. And then we cut the ureter. We can cut it above or we can cut it below. So we have decided to cut below. Another satisfying thing for me in diagnosis is that after cutting the ureter at the PUJ, there is no urine coming from the pelvis. And this confirms that there is an intrinsic factor to the PUJ as well, apart from the extrinsic factor. So we grab the cut portion, and then we mobilize the lower part of the pelvis enough so that the anastomosis is performed in a good fashion without any tension, and there is no surrounding adhesion, so that there is minimum chance of recurrence of the PUJ after reconstruction. So we mobilize more of the pelvis and from the surrounding tissue, keeping in view that there is no other aberrant vessel which may be injured in the process. So this lower portion of the pelvis needs to be mobilized a little more so that it avoids any tension during the anastomosis, and we also clean the area where we are deciding to do a redundoplasty of the pelvis. A little more mobilization of the ureter, of course, with the periureteral sheath, and we then check that whether it is reaching the pelvis easily or not. And then we spatulate the ureter. Remember, the spatulation should be at least 2 to 2.5 centimeters. And then we excise the part of the pelvis and the PUJ which is obstructing. Remember from the previous lectures, do not over excise the pelvis, because that if you are stretching the pelvis and you are cutting it, you would attempt to cut more and more of the pelvis, and by the end you find that you have also arrived upon the calyces. So try to excise minimum. Later on, if you want, you can cut more, but once you cut excessively, you cannot reattach the cut portion. So I usually cut the pelvis from below, and I leave the uppermost portion of the cut pelvis that can be used for retraction. And then we place a 4-0 vicryl suture outside in the ureter, and then inside out in the pelvis, in the lowermost part of the pelvis. And then we apply a surgical knot, and we can see that the ureter has joined the pelvis without any tension, and there is redness on the edge of the ureter, which is also quite satisfying. And then we pass the needle or the suture below the first knot, and we are going to make the needle pass through the edge of the ureter to the inside, and then we repair the ureter and the pelvis from the inside. I prefer continuous suturing. However, some would prefer interrupted sutures. Some would prefer a combination of interrupted and combined and the continuous suture. It is a personal choice. Both have their reasons for such anastomosis. However, I have seen that pediatric urologists they prefer and they like to perform interrupted sutures. However, majority of the adult urologists they perform continuous running suture. So far as the suture is concerned, one can use 4-0 vicryl, 4-0 PDS, or a new suture which is good for laparoscopic repairs is the V-lock suture or the Stratafix suture. V-lock suture is a feature of the covidian, and stratofix suture is a feature of the ethicon. But the problem with that is that the suture available is the most minimum size is 30. However, it is good and it is barbed and it stays and doesn't loosen. So then we grab the opposite side of the first stitch, and this makes the other side of the anastomosis visible, and we take same suture like that, and then we knot. You can see that there is alignment of the suture and the needle holder, so that the knot can be taken easily. There are different ways of taking knots. The C and the reverse C is one method, the gladiator is another method. So we cut both the suture ends. Then I place a small 2 millimeter port for mini alligator, and through that port I place the guide wire and the stent. The stent I place after taking one suture in the opposite side of the anastomosis, because if we take that stitch and the stent is there, there is a chance that we may take a stent in the stitch, which will be a disaster. So the stent is placed easily, and then we direct the loop of the stent into the pelvic ileal system. It is good to place the stent, the upper end of the stent, in the upper calyx. However, it is a horseshoe kidney, and this is enough. So the same 2 millimeter port is used for the mini alligator, so we can grab that cut portion of the pelvis, and this can be a help in retracting the pelvis so that the anastomosis is performed. Again, a continuous running suture with a 4-0 vicryl. The principles of pyeloplasty, whether it is a horseshoe kidney, whether there is a normal kidney, whether there is crossing vessels, whether there are no crossing vessels, the principles are the same. Always try to maintain the vascularity. The anastomosis should be without any tension. It should be a watertight, absorbable suture, and there should be adequate drainage in the form of a DG stent or a nephrostomy, and there should be redendoplasty. The diseased portion should be excised, and the anastomosis should be watertight. So these are few basic principles, and the final shape of the anastomosis and the pelvis has to be a funnel shaped pelvis. So here the anastomosis of the anterior and the posterior wall is complete, and the anastomosis of the ureter to the pelvis is complete. So now we proceed with the repair of the excised pelvis. So much of pyeloplasty is done. Now little job is remaining. So both the sutures are then tied to each other. All the tail ends are cut, because in laparoscopy they can make a lot of trouble by coming again and again in the way. So it's better if they are not required, they need to be cut and removed there and then. Remember, here we have cut the suture of the other side, but we have not removed the needle, and we placed it on the kidney, and we will remove both the sutures together. You can see that grabbing and retracting the cut portion of the excised pelvis and the PUJ is playing a vital role in making the suturing of the pelvis without any special effort. So it has simplified and made our job easier. These are small tips and tricks during laparoscopy which can make your life easy and make the procedure easy and save time for you, because if the time is saved and the energy is saved and the outcome is better. Here we are excising. Yes, the excision is now complete. 1 or 2 stitches are remaining, so we'll close the upper end of the pelvis with 1 or 2 more sutures, and then we are going to excise the attached portion of the pelvis, and then we are going to clean all the area. You can see that I have placed a gauze piece for cleaning of the area. So the Anderson-Hyne's pyeloplasty is complete now, and we can cut the extra portion or the excised portion of the pelvis, keeping in view the renal vein so that it is not injured, and then we cut the sutures, and then we take both the needles together and we count them, and then we wash all the area, reduce the pressure to 6 to see if there is any bleed. We also remove the gauze piece, and then we place a 20 FR drain inside the abdominal cavity in the pelvis. Thank you very much for watching.